Good morning, everyone. I'm Dr. Tara Karen. I'm a family doctor at St. Michael's Hospital and also the Vice Chair for Quality and Innovation at the Department of Family and Community Medicine at the University of Toronto. Delighted to bring to you this special session of our COVID Community of Practice. It's co-hosted with the Ontario College of Family Physicians, and I'm going to turn it over to their president, Liz McGaugh.
Thanks so much, and welcome everyone. Really glad that we can all join together. It seems like every time we meet, there's something new to share, and this is absolutely the case today. So we have a great panel for you. This session is MainPro accredited, so those details will be sent to you. You can see who our panelists are, so they will be introducing themselves. So I'll let them do that in just a moment. We'll move to the next slide, which is our land acknowledgement. So we acknowledge the lands on which we are hosting this meeting include the traditional territories of many nations. The OCFP and DFCM recognize that the many injustices experienced by the Indigenous peoples of what we now call Canada continue to affect their health and well-being. The OCFP and DFCM respect that Indigenous people have rich cultural and traditional practices that have been known to improve health outcomes. I invite all of us to reflect on the territories that we're calling in from as we commit ourselves to gaining knowledge, forging a new culturally safe relationship, and contributing to reconciliation. And as always, I'm calling in from Ottawa, the unceded territory of Algonquin and Anishinaabe. I'll pass it back to you, Tara.
Thanks, Liz. Next slide. I just wanted to remind folks that part of our job, of course, is to help with their doses, and we're going to talk more about that. But in particular, there are actually many populations, unfortunately, who haven't gotten first and second doses disproportionately, and unfortunately, Indigenous populations in urban areas are among those. And so we have, this is our opportunity to do that one last push. And I'm just posting here the resource for some Indigenous-led vaccine clinics that are in the Toronto area. I know you will have different resources in the region you're in. Next slide. A reminder that I know that this session is unusual and that it's going to last until from 8 to 9:30. I know that some of you will have to leave at 9 a.m. But please be aware, we're going to post the recording of the session afterwards as soon as possible. So definitely by end of day on our website, and you'll be able to watch the end of the recording or the full recording forwarded on to folks. And that watching it afterwards is also actually MainPro accredited. Next slide. So I'm delighted now to allow our panelists to introduce themselves. We're really lucky to have many busy people with us today. Next slide. Next slide. And of course, our lovely co-hosts. So Peter, I'm going to turn it over to you to introduce yourself and speak to your conflicts.
Yes, Peter Juni, general internist, epidemiologist, currently the scientific director of Ontario's COVID-19 Science Advisory Table. My day job would be, but I handed it over to run the Applied Health Research Center at St. Michael's Hospital. Previously, I designed trials, advanced statistical analyses, observational studies, all sorts of things, with a focus mainly on cardiovascular and musculoskeletal health. And since 1st of March 2020, I've done nearly nothing else but COVID-19. Sorry, and my conflicts relate to either trials that haven't got to do anything with COVID, and there were no honoraria, etc., that I ever got privately or so, nothing whatsoever from nobody. And we had, Allison and I had a trial that we weren't able to complete that was funded by Apili Therapeutics.
Thank you. Sasha?
Hi, everyone. Sacha Bhatia. I'm a cardiologist in Toronto. And for this presentation, I'm the executive in population health and value-based health systems at Ontario Health. Sit on the senior management team. I don't have any disclosures that are relevant.
Shane?
Hi, Shane Tepper. I'm the Deputy Chief of Family Medicine at William Osler Health System, along with lead physician for our Queen Square Family Health Organization, and involved with our local and regional COVID response with respect to vaccination, testing, assessment, and planning with our partners in the region. In terms of other disclosures that I have helped advise or a panel with respect to sotrovimab and getting that into the community with GSK. Thanks very much for inviting me and including me today.
Thank you. Next slide. Allison.
Good morning, everyone. I'm Allison McGeer, and I'm an adult infectious disease physician at Sinai Health System with an interest in adult immunization. And as you can see, I have relationships with most of the companies that have licensed COVID-19 vaccines in Canada and with companies that have or are developing antivirals.
David.
Hi, everyone. I'm David Kaplan. I'm a family doctor here in Toronto and the Vice President of Quality at Ontario Health, so a colleague of Sasha's. And I receive an honoraria for this series and salary support from Ontario Health. Glad to be here this morning.
Thank you. And Liz.
As I said, family doc in Ottawa, and no conflicts to declare. I receive a stipend for my role as president of the OCFP.
Next slide. And I've just listed some of my own funding sources for grants and salary support, as well as speakers honoraria. Only 2 are from for-profit companies, and they don't pose any conflicts for today. Next slide. So thank you for joining us. And I see that so many of you are already putting your questions. You know how to interact. Next slide. So just a reminder to post your questions in the Q&A box. But if you have resources or thoughts, reflections that you want to share, please do use the chat for that. I think we always value hearing from you, and we always learn from our attendees as well. Next slide. So, I mean, I know all of us are feeling pretty nervous, pretty shaken, probably pretty overwhelmed. At least I'm feeling that way these days. And there's a lot going on, and things are changing on a daily basis. And I feel really grateful that Dr. Peter Juni is here to start us off, to just tell us a little bit. And Olivia, you can go to his slides now, just to tell us a little bit about what we know about Omicron. We know that cases are skyrocketing, and what can we expect in the coming weeks? And what can we as family doctors do about it? So I'm going to turn it over to you, Peter.
Sounds good, thanks.
Olivia, if you can just bring up Peter's slides.
Okay, can you hear me? Yes, you do. So next slide, please. So that's how it all started. This is a logistic growth curve from South Africa. What you just need to look at is the slopes early in the pandemic, and now the red slope to the very right, that basically just shows you how quickly Omicron took over South Africa. This was extremely fast, and there were quite some people out there who said, well, there must be an anomaly. Let's see whether this was an anomaly. Next slide. Here then see the cases, how they skyrocketed up as a result of Omicron taking over in the province of Gauteng. So that's a province of 15.5 million. It's very comparable with population size, but I'll talk about that later, only in population size. You just already see the orange curve of hospital admissions. We talk about that then a bit later, what that means. Next slide. Now, how does it take over Ontario? That's the question. And what you see here is 3 logistic growth curves that I update daily according to 3 different data sets. You see it, CCM Plus, Mount Sinai, and PHOL. They all tell you the same story, that based on what we're seeing here, you know, we're on track to have the same rapid takeover. We don't know whether this will play out a bit differently versus the end of the takeover, but it's clear that 2 days ago we crossed the bridge and had more than 50% of cases caused by Omicron. Next slide. And this you can also be seen just here. You know, this is our I'm not even sure how to say that in English, the backwards and forwards between orange and blue, depending on what kind of mutations were present. So, the N501Y that originally was present in alpha is now present again with Omicron. What you need to see on this slide is basically the slopes, how things take over. Even though each time, things get more pronounced with more transmissibility, the slopes get steeper. So the first slope downwards is less steep than the second slope upwards when Delta took over. And now the third slope downwards again, when now Omicron takes over, is steepest, even though Delta is more transmissible than Alpha, and Alpha was more transmissible. Obviously, that's the reason for taking over, or one of the reasons, than the wild type. That's evolution in real time. What you're seeing here, it's if it wouldn't be so tremendously challenging, I would just be only fascinated by what's going on. It's remarkable. Next slide. Now, it's important, just to address these issues related to severity. I sounded like a broken record during the last few days on the media. I think a few things need to be clarified, and I would like to expand on that just for 2, 3, 4 minutes or so. Next slide. The first things that you need to understand for the province of Gauteng is that when you triangulate all the data we have on excess mortality, serological testing, take into account, that serologists have a low sensitivity to be positive if the infection has happened 12, 14 months or 16 months ago or so. When you take all of that into account, then you need to assume that approximately 90% of the population in the province of Gauteng was infected at least once. In this province, adults were vaccinated in about 36% of cases, meaning most of those have a combination of at least one infection and 2 doses of a Pfizer vaccine, which makes you an immunological superhuman. You have a broad, robust immunological response, but all of those who are infected have a lot of, T and B cell activity, residual activity, long-lasting plasma cells. This will all help your case if you have been infected before. So what this means is that based on everything you will be seeing and everything which is circulated in the media, there's absolutely no evidence that we can tell anything about the virulence in non-immune, unvaccinated people. That's the challenge we're talking about. And of course, remember our median age is 41. This is against 27 in Gauteng, and less than 5% of their population is above 65 years of age. Next slide. Now, this is really important. This is coming originally from Adam Kucharski when he reflected at the beginning of the pandemic about deaths. For us, this is mostly an issue about health services use, especially ICU admissions. So what you see here basically is a base case in gray on the bottom. Over time, when the epidemic or the pandemic actually develops, and then one situation where you have a strain that is more severe and the other situation where you have a strain that is more transmissible. And the question is, how many ICU admissions do you end up with over time? And this is important. Transmissibility always rules. You don't really care about, a bit less or more severe. As long as this less or more severe is not dramatically different, you always need to look into the transmissibility issues. Of course, right now, the transmissibility is not only intrinsic transmissibility, but it's also the capacity, as we will see in a moment, of Omicron to evade the immune system. Next slide. So coming back now to what we said just before, I've shown you this slide already. What is now important just to realize, okay, cases explode in blue in Gauteng. And what you then see, if you just change the scale, that this explosion of cases is exactly tracked by hospital admissions per day. So, there is no decoupling between hospital admissions and cases. It's just that you have so many cases, and most of these cases are in people who are either partially immune through just infection, or nearly fully immune through infection and vaccination. What you're basically seeing is an inflation of the denominator. And everything happens at the lower level if you start to calculate the risk of hospitalization per case. But it's basically the same story. The vulnerable end up in hospital, and hospital admissions track case counts. That's what you would expect, and that's what's happening. But, this doesn't make it into mass media, unfortunately, or not necessarily at the beginning, at least. We're in a better situation in Canada, but many other places are still completely asleep at the steering wheel because of this issue with, oh, it's mild, we don't have to worry. Next slide. When we then go to other places and just look into places like London, where again, Omicron has taken over, what's happening in London right now regarding this tracking? Next slide. London, UK, it's exactly the same. No? So what you see basically is case numbers going up, and hospital admissions here, they have, just an inflation factor of 50. And of course, a 7-day time lag here just included. What you see is basically hospital admissions are tracking case counts. That's what you would expect. So if you ever hear again that somebody uses the term decoupling here, you should basically just put the record straight. Next slide. That's the situation in Denmark. This was also, in the presser that Steny gave yesterday, Steny Brown. Again, early data, but we don't have any indication even whatsoever based on this more reliable data, because they have a really good surveillance system in Denmark. There are a few places that do that really well. We're one of those. Denmark is another one. What you see basically is in these early data, there's no indication that the risk of hospitalization would actually be less relative to cases. Perhaps it will be a little bit, but it doesn't help you. Remember Adam Koczarski's slide that we adapted, or that I adapted for the purpose of this presentation. Next slide. And here is now hospitalization on the scale that you see to the left in a dark blue versus what then happens in hospitals regarding patients in ICU, patients receiving supplementary oxygen or mechanical ventilation. And again, what you see, I haven't, transformed all the scales there. Basically, apart from perhaps mechanical ventilation, ICU and receiving oxygen is tracking basically the patients in hospital. So what you see when you just take all of that together is we have the same patterns, but we have a massively inflated denominator of cases. Why? We will see that in a moment. Next slide. And here is now a comparison of the waves. Again, we also created these slides for the press conference, but you really need just to be aware how these waves compare. And, we had standardized criteria how to define the beginning of the wave. What just happens early on is an explosion of cases in South Africa in general. That's not Gauteng now, it's entire South Africa, based on our world in data and additional data from South Africa. Next slide. And this results in a never before seen early increase in hospital admissions that could also, despite the situation that the South Africans have, lucky for them, result again in a real burden to the healthcare system, which obviously will be much worse for us since we have had so few infections, luckily for us in the past. And since we continue to have a pocket of about 15% of the population, tragically, a lot of people who were disenfranchised in the past, as pointed out by Tara, who are not vaccinated yet. And that worries me most, actually, when I think about the indigenous population in Toronto, for example, who is not vaccinated because they experienced systemic racism in the past and therefore justifiably so distrust the system. This is a dramatic situation we're talking about potentially. Next slide. The good news for people who are at least partially immune is, if you remember the first two slopes that I've shown you in orange, it seems true that mortality in people who have experienced some exposition with the virus, either through infection or through vaccination, mortality might be I use the term now here, decoupled, which would be great news. I hope this holds also for the elderly. They have not many elderly people, as we said before. This would be great news if this were the case for our long-term care homes, because I'm genuinely worried, because of outbreaks there, of course. We will see how it goes. Next slide. This is now just a series of a few slides that just show you the same thing. Basically, neutralizing ability of antibodies caused by previous infection or caused by vaccination decreases perhaps 20, perhaps 40-fold in the presence of Omicron. That's the challenge. Next slide. You see the same here. It's just a problem. There was already some immune evasion with Delta. It's just got much, much, much worse. Next slide. What this means, luckily for us, if we talk about comparing vaccinated and unvaccinated people, that's an early slide I used that I did very early when we saw what happened in Gauteng, but it still holds. Vaccinated and unvaccinated people in Gauteng, but remembering that the vaccinated and the unvaccinated, most of them have experienced at least one infection, meaning the vaccinated are actually, again, immunological superhumans who typically are better off than somebody who just received their booster shot potentially. I'm not quite sure whether that statement is true, but they're probably not worse off than somebody who has received a booster shot. So the combination that you see here, or the comparison, is basically infection plus 2 doses of a vaccine versus just infection. And if you look at that, then you have a relatively high vaccine effectiveness against hospitalization, but it's still much lower than what we saw, of course, for the previous variants. Next slide. That's early data from the UK indicating that it's absolutely right, and that therefore we worked on that very early on here with the province, to now just have a shortened time window until the booster and really get the booster or the third dose of the vaccine in the presence of Omicron. First of all, this vaccine has become a 3-dose vaccine in the presence of Omicron. Second, after 3 months, your vaccine effectiveness against infection, this is infection, not hospital admission, decreases so dramatically that a time window of 3 months is absolutely justified. After 3 months, we need the third dose. And now let's hope, fingers crossed, that we get, a robust, broader, more mature immune response, so that the effectiveness actually increases really quite dramatically, as you see it to the right, so that the boosters longer term also start to contribute to the protection of the population. But this is longer term. You heard it in the media repeatedly. There is no way that we can't just vaccinate ourselves out of this current wave. It's impossible, because we can't vaccinate, 6 million people just in one go within 2 days. If we could do that, the situation might be different, but we can't. We need to roll out this slowly, and it will help mainly to protect those who receive the shot. And for January, it will start to be an investment for the future, but not now. We can't get out of the wave just with third doses. That's an illusion. Next slide. That's a conclusion of what I just said. What we really just should remember is that the B and T cells and long-lasting plasma cells are here to stay if you had an exposure, and everything we see so far means they really will play an important role against severity, and keeping my fingers crossed based on all the preliminary evidence. Even if you probably just had 2 doses, and even if you just had an infection, you are much better off than if you never had an exposition, which means, if we just could get, all these populations out there, all these people out there who experience disenfranchisement and systemic racism to understand things has changed so much, this would be tremendously helpful if they at least got 1 dose of a vaccine, and then perhaps a second in a few weeks. Don't wait long, huh? After 3 to 4 weeks, they would need to get the second shot, and then they would derive some sort of protection that actually could be quite good, only not long lasting, but quite good. Next slide. Now that's our projections. It's hardly surprising now. if we're at 1,000 cases of Omicron per day and the doubling time is 3 days, meaning every 3 days the Omicron cases double, what does this mean? So today is Friday. Let's assume we're at 1,000 cases. On Monday, we're at 2,000 Omicron cases. On Thursday, we're at 4,000 Omicron cases. And on the next Sunday, we're at 8,000 Omicron cases. You can do that just yourself. I hope it won't be as pronounced because there are some social network effects. This thing right now still hangs more prominently in Kingston than in other places. Kingston is just completely out of control. But it's clear it has taken a foothold nearly everywhere, and we will see what we see in Kingston now also coming in other places of the province. And that's why what we need, in this situation, again, once more, remember Adam Kucharski's slide on severity versus transmissibility. We need additional measures now. We need a circuit breaker, otherwise we won't be able to pull that off. I didn't include the slide, but just to make that clear once more, people out there, I'm just talking now about those people who are unvaccinated and never experienced an infection. Those people out there, given their age structure, still have the potential to create more than 10,000 ICU admissions. Just when they experience infection, given their risk that they bring in, given their age, assuming their risk factor profile is comparable to the risk factor profile of vaccinated people, which is a mighty if. Probably the risk factor profile of those who are not vaccinated is worse. But age is the most important risk factor. So more than 10,000. Now, when you think about these curves that we're talking about here and think about that the wave that we're talking about could just, go through within 6 to 8 weeks. And after 6 to 8 weeks, nearly all the unvaccinated are all infected. This means these 10,000 ICU admissions would happen in a very short time frame, and our healthcare system couldn't cope with it. And only if Omicron would be 10 times less severe, meaning they would only cause 1,000 ICU admissions rather than 10,000, the healthcare system could cope with it. This 10 times less severe is absolutely impossible from a biological point of view. It's not perhaps absolutely impossible. There's always a lottery ticket that you can win, obviously, but it's extremely, extremely implausible that this would be 10 times less severe. And basically, as a matter of fact, initial data coming from South Africa, that's optimistic. You remember all my caveats that I gave you just suggest that perhaps it's 25% less severe. What is 25%? That's just a pipe dream. If it's 50% less severe, meaning 50% less ICU admissions per case count, whatever, you just wait another 3 days and then you have twice as many Omicron cases and you just have compensated for this 50%. You get the message. Next slide. And here's the associated, estimate as it's just for end of December for ICU admissions. Look at, the upper range. It could also, even get more problematic than the upper range here. The point really is just to realize in January things are most likely quite challenging, especially if we don't react now very swiftly. Next slide. Some preliminary conclusions here. Somebody already was talking about sotrovimab. I didn't take this forward, but what you need to understand is sotrovimab is the only antibody that works, and everybody should just be aware of that. We have our updated guidance then on our website of the science table. So sotrovimab is the only antibody that still would work. The other two drugs, and there will be specific indications where you could use it theoretically, and hopefully Shane or so will be able to talk to that a bit. The other two drugs that you can just use potentially is fluvoxamine, the antidepressant, and budesonide, the inhaled corticosteroid. Again, you will find guidance on those on our website of the science table. And then, the rest that you see here is just what we would need to do the circuit breaker. Meanwhile, the third dose rollout has been accelerated, obviously, and the congregate settings are, as Allison can speak to, a real scare right now. This is a real problem. Next slide. Next slide. Just very quickly, this was a slide we did on our rapid testing brief included on our website for Delta. The point is, most likely Omicron is even earlier and peaks even higher with the viral load. What this basically means, as long as the tests fundamentally still work, and everything points towards that, the rapid tests still work with Omicron, because rapid tests use nucleocapsid as antigen, and in the nucleocapsid region of the virus, there weren't many mutations anyway, but also we've seen that it works, basically. So what you see here, that rapid tests could have an edge compared to previous variants in the presence of Delta, probably is also true for Omicron, most likely. Next slide. So next slide. You will have a lot of indications. You can go to our science brief and look into that, where you could use rapid tests in the future. Right now for you is most important just to keep your workplace safe. Your most important thing to do in your situation, because we will experience a different phase of the pandemic now, a lot of infections in any cases. You need to keep yourself, your family, and your staff and the system safe. So you need to focus on doing that first. This is like basically being in an airplane. First, use the oxygen for yourself before you help others. So this is the prerequisite here now. Third doses for everybody in your surroundings, your family, your staff, etc. Same in the hospitals. Everybody needs to do that first, and then use rapid testing well for voluntary screen testing, roughly twice a week. And then even if people were exposed, for test to stay, that's not only in schools, test to stay will need to be expanded. We will have a lot of test to stay in the future. Bus drivers will need to continue to drive their buses, even though they were exposed. So they need to do daily tests, rapid tests, etc. Perhaps teachers in the future, but right now it's mainly healthcare system where you need to get this all started. But also all the other aspects are important. Remember, if there's a rapid test, this may change because we don't have enough testing capacity relatively soon. But if there's a rapid test that is positive right now, we would assume, okay, PCR confirmation. Next slide. Here is just the peak viral load of Delta. It's very high. Same, most likely the case for Omicron. Next slide. I'm about to finish, Tara. If you go to the next slide. Just a point to be made. These tests work well if the CT value is relatively low, 30, we still have a sensitivity of 80%. At below 25, you have a sensitivity of 96%, and the specificity of these tests is excellent. And we used basically for all our calculations on our science brief, the more conservative value of 30. Next slide. At 30, basically, you will have viral loads or below 30 in nearly all the cases of more than 100,000 copies per mil, meaning basically that that's the cases that could be potentially infectious. If you then approach 1 or 10 million copies per milliliter of viral load, you have a really high risk of cultivating the virus, and you also see in household studies more transmissibility. None of that will change for Omicron. Next slide.
Sorry, Peter, I'm just going to ask you, can you explain what CT is? Because
sorry, CT values, sorry for that, if you go one slide back. So CT values are cycle threshold values. If you do a PCR, you basically need to prime. And what you then do after that, you basically amplify the material, the signal you have in your sample through the PCR technology. Actually, Allison should talk to that. She's a lab specialist, not me. So you correct me if I talk nonsense, Allison. And basically what you do is you amplify, and each round of amplification that doubles the material, is basically a cycle. And the more cycles you have, the more amplification goes on, meaning if you need to basically use 33 cycles to amplify, this means there was a very low viral load in the sample you had because you needed to amplify it 33 times. If you only needed to amplify the RNA that you're trying to detect 12 times, then this means that you basically have a high viral load. So there's an inverse correlation between CT value. High CT value means low viral load, and conversely. Does it make sense?
Yes.
I think so, huh? Okay, next slide. Now this you need to ditch. Based on everything I said, we had that in our science table brief. We will update it now for Omicron, hopefully by Monday. There we distinguish between vaccinated and unvaccinated. Forget about that in the presence of Omicron. If you're more than 3 months down the line after your last vaccine dose, if it was the second, not the third, then you're most, for just daily purpose, you can just say you're as likely as somebody who is not vaccinated to get infected. You're still much less likely to end up in hospital based on based on everything we know, but you're not less likely to get infected and therefore transmit. Therefore, the slide here where we, just worked with pre and post test probabilities, etc. You can forget about that. You don't distinguish anymore. Everybody needs rapid tests if you start to do that. Last slide, the next one is, and in the situation we're approaching, in many situations, we will just be in C, explosive outbreaks relatively soon. And this means you need to do rapid tests. If you do that in asymptomatic screen testing settings, at least twice a week, but probably 3 times a week to get most bang for the bucks. If you just do it once a week, forget about it. You don't even have to try and start because it's completely inefficient. You will not reduce case numbers because this is all so dynamic now. Next slide. I think it was probably the last one. Lucky me. Yes, it was. Handing over to you guys.
Thank you, Peter. Thank you for everything that you've been doing. I know I've seen in the chat others thank you as well. We're really lucky to have you at the head of the science table. I know, Olivia, you're going to be bringing up Sasha's slides next because I wanted to give Sasha an opportunity to speak to the health system response. I know many of us are feeling it's sobering and probably overwhelming for a lot of us hearing what Peter has had to say. Olivia, while you're getting up Sasha's slides, maybe I'll turn it to David, who I think has his hand up.
Yeah, thank you, Tara. There's a number of questions about accessing PPE, N95 masks, and rapid testing for our offices. So I'm just going to direct people to the chat. I'm going to post the link where family physicians can order rapid tests for their office to do, as Peter was suggesting, as well as N95 masks for looking at if they're going to be looking after suspect or confirmed COVID positive patients. I just wanted to point that out for people.
All right.
I think, David, there is one point which is a bit of a challenge. Nearly all the transmission will happen pre-symptomatic. So, you know, we could end up in a situation where 5% of the entire Ontario population is actively infectious at the same time. So there is not much sense into making this distinction then in the future. It's again, the landscape will just change, you know, and it will depend mostly on what we believe is if we're in continuous exposure or not. Like a bus driver, for a bus driver, a better mask makes more sense than in many other situations.
You know, one of the things, Peter, that would be helpful to comment on is many community-based family physicians are not mask fit tested. Yeah. And I think one of the questions that many of the colleagues on the screen or in the line have today is it okay if they're not mask fit tested to use an N95 mask? I think a number of the communities are trying to figure out how to mask fit test a whole bunch of family doctors that have never been mask fit tested.
Remember, there are also KN95s, which probably are quite a good compromise. They have the same filter, are much more comfortable. They don't have to be fitted, and you just look into, it's all about, we need to be very pragmatic, you know, with these weeks to come. Basically, we just do it as good as it gets with rapid tests, with masking, etc. The best mask you can get your hands on is great. If you're exposed, not people like me, we just sit at home. We don't need even a KN95, no? But people who are out there exposed, just use what you can get. And perhaps Allison can speak to the fitting issue. My experience is if they're not fitted, the N95, it could actually even, result in more gaps. That's my personal experience. But then, the KN94 or KN95, relatively cheap, you can get them, could be a good compromise for people who are quite frequently exposed, meaning exposed to what? Exposed to other people.
I think, honestly, even N95s or KN95s are fine. When you put them on, you seal them and breathe in and you get a measure of the sense. There's quite a bit of variability between different N95 respirators and different fit, but I think, in the circumstances, they reduce inward flow overall, even if they're not fit tested, more than regular masks. So they will be a benefit even if people are not fit tested. And the other alternative, as people have done studies on, is to actually, if you just have a medical mask and you want better seal, is actually just to use something like tape to seal the surfaces of the medical mask, right? It's all about getting a fit to your face. So I don't think we should be, in the circumstances, I don't think we should be too possessed with getting fit tested people. Masks will still be better.
Thanks. So I'm going to actually turn it to Allison in a minute to talk more about that, but I actually just want to turn it to Sasha at this time to give an update from Ontario Health, and he's going to talk a little bit more about what you touched on, David.
Great. Well, thanks so much, Tara, and obviously thanks everyone for being here, and thanks for Peter and Allison and everyone on the panel for all the work that they do. I'm here again in my capacity as the senior executive, at Ontario Health that will be liaising with the ministry and the CMOH on in large part on our community response. And I just want to give you guys an updated. But before I do that, just also want to say thank you. I don't think we say that enough, particularly to our family physician colleagues. Since March 2020, I know that you have all been, engaged on the front lines, seeing patients with COVID, working in assessment centers, vaccinating, and doing all kinds of amazing work, including keeping your own patients safe. And truly been heroes, I think, in this pandemic. And looking at the data, Peter says, it obviously saddens me that I have to come here and ask for your help one more time, because this is obviously something that we haven't seen before. We've certainly seen other ways, but nothing quite like this. And so, next slide. I think what we recognize is how important the primary care sector has been in our pandemic to date, but also how important you are going to be, in the coming weeks. If you just look at Peter's data, where we really need the support will be in a couple of areas. And I want to be very clear that there is no space between the Ministry of Health, Ontario Health, the CMOH, all of our hospital and regional partners, on the messaging here, which is we are really looking, to do two major things. One is the maintenance of essential and critical clinical services. We recognize that if Peter's data is correct, which we have no assumption to believe it isn't, that our emergency rooms are going to be very busy over the holidays and coming into January. And as much as we do to maintain essential and critical clinical services in offices to keep people out of hospitals, I think will be really, really important. We recognize that, and the second, critically, which you've heard from the Premier and you will hear from all of us, is going to be the step up on vaccinations, immunization efforts. Peter's absolutely right. It's not going to be critical. It's not going to help in the next couple of weeks, but it could help, certainly blunt some of the impact in January. And so resource allocation into these two areas is going to be critical. It will mean making some choices. And that will mean, and I've been, up with others talking about the need for things like preventative care, which has been lagging in the pandemic, issues around, deferred clinical care that I don't want to say is not essential, because actually, quite frankly, it's all essential right now. But we need to really stream into a couple of those areas. There are a number of resources. And the other thing, I really want to say is, while this is a terrifying epidemiologic threat, we aren't starting from scratch. And so there have been a lot of infrastructure, time, energy, effort, and resource that have been put into building a response to COVID, and a lot of connections that I think can be helpful. Next slide. So we do have a fairly robust IMS structure, and I think in all of the 5 regions, which I think is really important, and they're really being led regionally with central connection. And certainly there is, with our new CMOH and with the deputy minister, Matt, our CEO, meets with them regularly. We are again working as much as we can in lockstep on our response. We also have connections with public health. Many of, and again, to be very clear, public health units across the province have developed their own immunization plans. They're really the quarterback of how we're going to be doing local immunization efforts. But make no mistake, Ontario Health, particularly through our regional structures, through our health system partners, including our hospitals, are being commandeered, are being utilized, and will be utilized, to support the infrastructure. I know there's been a question around whether or not public health, how do I get in contact if I'm a primary care physician and I want to engage, in the local effort. We will provide we have a list of all of the primary care contacts in public health that, we'll provide to the OCFP, and that can be distributed. So in your local area, if you want to step up, be part of a mass vax clinic, get supply in your office, we'll provide all of the contacts for that. If people are having challenges around getting vaccine supply, you can reach out to us directly. We have contacts in the ministry. We have been working on the ground, with our partners in public health and in the ministry to make sure that there's appropriate vaccine. So, we know that there are, individual distribution issues, but we're working through that for sure. But just to know there is a distribution channel. And the other thing I'd say is in your regions, our hospitals are playing a role. And I will, again, provide contacts to all of our regional VPs who are in contact with primary care leads in all of the regions, who again can help to answer questions about how you want to connect in with a hospital. In the hospital clinic, you can as well. Next slide.
Sasha, I think there was a question in the chat about what the IMS structure is. I think many
an incident management structure. Sorry, I should have clarified that. Basically, there is a COVID table in every region that is chaired, that has a number of subcommittees, including primary care, including hospital response, including questions around PPE. So the point is, in every one of our 5 regions across the province, there is a structure that is in place. Again, there are connections in for primary care physicians if they want to, connect in, ask questions, understand how they can be involved. And I'll make sure, that we provide all of those contacts to the OCFP for wide distribution. The last thing I'll say, because I want to give time to my colleagues, is to say that there is, again, there are resources that are available. So primary care offices, in response to, the OCFP's questions, are available to primary care providers through the pandemic stockpiles. This includes, rapid antigen testing. This includes all the appropriate PPE, including N95 masks. I want to be really clear, the N95 masks that we have the most supply of are domestically manufactured 1870 plus masks. If you have been fit tested and you require something else, often those are foreign sourced and availability may be limited. I've been told by our people to say that at 1870 plus come in boxes of 400. So don't be afraid if you see this massive crate that comes to your office. It's just kind of how they get packaged. We have rapid antigen testing, we have swab kits. So all of that can be provided. There's a link here. And again, we'll provide all of this data to the OCFP for again, wide distribution, but it can all be gotten online. So again, I recognize that this is like extraordinary times. We will do everything that we can to support our primary care physicians, our family doctors in the amazing effort that they've done to date and what we're going to ask them in the next little while. And we communicate pretty regularly, I'd say, with our primary care colleagues like in the OCFP and others, and we will continue to do so. And we will update you guys whenever we get that information. And we again want to maintain open lines of communication through this very difficult time. So thank you very much.
Thanks so much, Sasha. So I mean, I think people really appreciate this link. I am hearing some follow-up questions, but I want to get to these, which is sort of what is non-essential? What about ERs being overwhelmed? How can I use rapid antigen testings in the office? But before I do that, I guess I wanted to give one targeted follow-up to you, Sasha, and then I'm going to turn it over to Allison to talk a little bit more about the IPAC guidance. But the follow-up for you, Sasha, is just that there have been some people in the chat who've mentioned that they have tried to order N95s using this website and process, but that it's been declined or rejected, that request. So I don't know if you could speak to that, or if that's something you can take away.
Yeah, I can speak to it because I may be a little closer to it than Sasha.
Go for it, David.
Yeah, so originally, prior to the new guidance that came out this week, we were only providing N95 masks to people who do aerosol generating procedures. And obviously the guidance has changed this week. I would remind people though, that this stockpile for PPE was set up when many doctors and other organizations didn't have access to ordering PPE. And if you see, Sash, the first point on this slide, this is over and above what could be fulfilled by your regular supply channels. And you can imagine if you're a solo physician ordering 400 respirators, maybe a little bit overwhelming for the system and even finding somewhere where to store them in your office. And you should try, aside from the rapid tests and the swab kits, you should try to order PPE from your usual suppliers. You will recall that early on in the pandemic, we couldn't even get it. So change in the guidance, but also you should be trying to order these things from your usual suppliers. And if you can't get them and you can't get them rapidly enough, then you should order via the link.
And I would say if people are continuing to have challenges, I'll take that back to our supply chain folks. It should be fixed by now because the PHO guidance has changed, but I will take it back to confirm.
So let's go to the next slide, Olivia, because actually that does quote the new PHO guidance. So this is new guidance from Public Health Ontario. And this is what David and Sasha and Allison were referring to previously. So I've summarized here some of the key take homes. And I guess the first bullet I do want to emphasize here is that they say, they emphasize that healthcare workers are at risk of infection from both occupational and community exposures. And I think that's really important to keep in mind because even by the questions that are being asked today, which are absolutely terrific ones, we're often focused on how to keep safe in our professional setting, when in fact, a lot of the risk that we have to ourselves and then by extension, providing, transmission to our patients and colleagues would be through our exposures in the community. So we really have to watch how we behave in those community settings. They emphasize the need for third doses, which we've heard. And then there's this third bullet point where they use this very specific language, and we're copied it here word for word, that the interim recommended PPE when providing direct care for patients with suspected or confirmed COVID includes a fit tested seal checked N95 respirator or equivalent or greater protection, eye protection gown and gloves. Other appropriate PPE includes a well-fitted surgical procedure medical masks or non-fit tested respirator, etc. And then fit test N95s should be used for aerosol generating medical procedures. So this language is a little bit difficult to interpret. I'm going to turn it over to Allison maybe to just speak a little bit about kind of what we should take away here in our settings.
Thanks, Tara. So, this is a personal perspective, but I think as we go into Omicron, it's worth thinking about a few things. The first is that Public Health Ontario, in that summary of data, are very clear that we don't have data that says that wearing a fit tested or any kind of N95 respirator actually improves your protection. There have been a lot of observational studies and they say a mess of different things. And probably what's difficult about that interpretation is that whether or not you wear a respirator may be confounded with other protective behaviors. And it's also difficult to measure the effect of protection in healthcare because we know that most of the risk for all of us is actually in the community, not in the healthcare setting. So, in Canada, there have been a substantial number of studies of healthcare workers, and none of them have been able to detect an effect of working in healthcare. People's infection rates look the same as other people in the community. That doesn't mean it's not present. It just means it's small enough that we can't detect it. And so, that makes it really difficult to know whether something you're doing in healthcare is protecting you from healthcare exposure. But it also tells you, as Tara's just pointed out, that for all of us, most of our exposure occurs in the community. And so PHO moved in this direction, not because there's new data saying that N95 respirators will be more protective, but because Omicron spreads so much more quickly, that there is a concern that the proportion of transmission that may be through small particle aerosols is greater for Omicron than it is for other variants. We don't know that with any degree of certainty, but it is reasonable to be precautionary about it where we can. That does not mean that layered protection, again, always, right? What protects you against anything is not one single thing, but a whole list of things that starts with third dose of vaccine and moves through the things that we know protect you from COVID. Good evidence that hand hygiene adherence, that distancing, that wearing like a mask, any kind of mask. You read the IDSA guidelines. The IDSA guidelines still say that you can't distinguish between a medical mask and a respirator for protection. Part of that, remember, is that there's two reasons that you wear a mask. The first reason is to protect other people from you. And from that perspective, medical masks and N95 respirators are not very different. The second reason is to protect you from other people. And in that setting, there are greater advantages to respirators over medical masks. But still, the most important things are hand hygiene, distancing, and everybody wearing masks. That's the beginning of what protects us. When we can layer wearing an N95 respirator, that may provide some additional protection. But again, remember, as I can't remember who just said on this call, most of the transmission from Omicron is going to be from pre-symptomatic or asymptomatic people. So the other thing to remember is you're not just using protection when you see somebody who's symptomatic, who you know is ill. We need to be using protection all of the time with everyone, and that includes colleagues, okay? SARS-CoV-2 is an equal opportunity infector, does not care whether your name is Peter Juni or David Kaplan or John Doe, okay? We're all at risk of infection, and you can as easily get COVID from me if you have an in-person meeting with me and my mask out as you can from one of your patients coming into the office. This is really about trying to be very clear that we're all adhering to preventive guidelines with everybody in our occupational setting at all times. And yes, adding an N95 respirator at the moment, because it's Omicron and because we're facing a crisis, is a good idea if it's accessible. I'm not going to be fussed if I see a patient and I don't have an N95 respirator personally, okay, not at the top of my list of concerns, but it's a good precautionary thing to do for the moment. That doesn't mean that we're not going to change our mind about it, okay, 2 months from now. And so the last thing I want to say is that information about Omicron is evolving really quickly. What we're talking about today may not be the same as what we're talking about tomorrow or the next day. And so this is all about sort of trying to get back to really careful basics of infection prevention, trying to make sure that we're only having essential contacts, whether that's patients you're seeing in the office or people that you're seeing outside of the office, and watching for new information coming so that we're trying to keep up with what is the best we can do to get through this. And like everybody else, thank you to everybody on the call. We all know who's doing the heavy lifting in this. It's been a remarkable achievement, what we've been able to do in Ontario so far from everybody protecting people. I have absolute confidence that we will get through this together, but I just want to thank you for what I know is really an incredible additional burden that is being loaded onto you now. Thank you.
Thank you, Allison, for answering that. Liz, I think you wanted to jump in.
Yeah, I mean, I guess I just want to be really practical about this and just say, like, I think we know that we know well that the IPAC PPE guidance is about the layering. So all of those pieces that we know are so critical. So making sure that the focus isn't exclusively on the masking. Let's remember, you know, the vaccination, ventilation, the distancing, all of those other pieces. You know, and I think that the guidance we're getting now is really for those patients who are symptomatic with respiratory symptoms, known or suspected COVID. So is there a possible risk? Yes, but let's remember how low transmission really has been in our healthcare settings, how well we have done with this. So I think we got to be practical about we need to keep our offices open. There may be some things we're not doing, things like PAP tests that can be deferred, for example, and, you know, there's been some examples there listed already in the chat, I know, and I know everything feels a bit essential right now, but moving some of those things to later, ensuring where we can to continue to provide that in-person care, and let's not lose our heads about this. We can do this, and we're given the time. You know, we know this is going to be a 4 to 6 week period of intense intensity, let's just say, and it can feel scary. I mean, I think that their uncertainty is really scary, but it's really important. We're in this together. We can do this. Take this time now to go back to your clinics, work together, lean on each other, secure your ship, talk about that whole range of things that we've been talking about, and know that we can pass through this. And honestly, I do think, and Allison, you've said this so well many times, like, remember where the biggest risks are for us. Honestly, they are out in the community and at home, which, you know, we acknowledge. So, but I just want to give people confidence in our ability to manage, you know, and I also want to give you assurances as an organization at the OCFP. We have been relentless and ongoing in our advocacy and communication back up to the ministry about we need clear guidance for our sector. We need supplies for our sector. And, you know, I think Sasha coming today is an indication of that investment in making sure we have what we need in those cases. And we will continue to do that. I've heard loud and clear today that you want messaging back to the public. That was something we were thinking about. We will do that. We're working on that right now. So stay tuned to let them know that what we're doing may shift a bit in the next 4 to 6 weeks. We will be there for you for what you need, the really essential work. But so just to let you know, that's also very much on my radar. I can definitely see that reflected in the chat, and we hear you, and we will provide that messaging back to the public as well.
Thank you, Liz. I think people are really reassured by your words. And Olivia, maybe I could just take you not to the next slide, but the one after that. And Sasha, I see your hand, but maybe I wanted to get to this first. So I think people are reassured, and I think, you know, people are reflecting on how we're not in the same place we were 18 months ago. We've learned a lot. We've got some immunity. We've got some vaccines. We know what works. We've got some treatments. So we're in a good place. So I think that was what Noah Ivers was said, and many people are just reminding ourselves they like that analogy you said, Liz, of securing your ship. And so I think this is, we've worked on this sort of this slide around what it is that we need to prioritize over the next little while. And so what is it that you can do? And so that number one there really is securing your ship. And that means keeping yourself, your staff, and the patients you're seeing safe, and that environment that you're seeing patients in safe. So please do ensure that all of you and your staff and your households have the vaccines that you are eligible for. Really discuss with your staff in your office, reducing the contacts in and out of the office. And we know that lunchtime and breaks and those kinds of things are high risk, where people are taking their masks off and eating together, talking to each other. Of course, it's Liz mentioned the ventilation, PPE. We talked about PPE. Absolutely, in-person care continues to be important. I think we are going to have to be more judicious, though, with who we see in person versus who we can see virtually, because when we are seeing people virtually, it is definitely lowering risk of transmission for them, including the transmission acquired through transportation to get to the office, and it's lowering the risk of transmission within our office setting. And so, I know the vast majority of you have been seeing in-person patients right through the whole pandemic. And by I say vast majority, I mean like 95% plus, right? And we know we've gotten a bad rap around that, but now, and we've been ramping up in-person visits, but now it's time for us to probably pivot back and be much more judicious, but at the same time, really ensure that we're seeing people who have healthcare concerns that need to be seen in person, so that we aren't, so that we are helping and doing our part to not overwhelm our emergency departments. And then lastly, of course, we've talked about supporting the boosters. And I think we're supporting more than that potentially, because we are soon going to see a system that's overwhelmed from a contact and case management perspective as well, and a testing perspective. And we're going to need to be there for our patients to navigate them through that difficulty. Wondering, Sasha, was it something that you wanted to interject there?
Thanks, Tara, because I think this is really helpful. And just on the sort of, virtual to in-person piece, I think the message is a bit nuanced. And that is that what we're really talking about is, we talk about urgent issues. And I know it's really hard. Like, after, 22 months, like all of my patients feel urgent, right? Because they haven't been as maybe seen in person or as often. But what I would say is, it really is, if we need to see people in person, we have the tools to do it. And if you don't have the tools like adequate PPE, you got to let us know through the channels that we've described. But the goal here is not necessarily what we had in March, which was a virtual first approach that was basically like virtual because we didn't have the tools that we have now to sort of maintain, a lower risk of contact. So the idea here is it's shifting the types of people that we see. And we're not saying forever. We're saying for a relatively circumscribed period of time. So as you can see from the modeling data, really to focus our energy on immunization and boosters, as well as, again, those urgent cases, the heart failure patient that has a bit more shortness of breath, the COPD patient, the person that has had unintended weight loss, the things where you're like, I think this person is really sick. Those are the people that we really need to sort of focus on. And that will be, again, with the goal here of maintaining as much of our ER capacity as we possibly can, because obviously we're really worried that our hospitals are going to be overwhelmed. So it's a bit of a nuanced message. It's difficult, but I think Liz and Tara provided some pretty practical sort of advice about how to do that.
Thanks, Sasha. So I'm just going to go to the slide previous to this, Olivia, because one of the reasons that secure your ship is so important in reducing contacts, at home, in the community as well as in the office is important, is that, this is spreading fast, and it's going to spread fast among healthcare workers potentially as well. And I wanted to just highlight here some of the change in guidance for case and contact management, or some of it is changed and some of it is consistent with prior. But I think, and this has been released just 2 days ago, I believe, and it hasn't been posted on the ministry website, but I think it will be soon. So the overall, and again, taking quotes here from it. So the overall goal in Ontario around case and contact management is mitigation of further transmission of Omicron by managing the highest risk transmission settings and mitigating outbreaks and transmissions. And there's, some great comments in the chat from Andrew Moser, who says that we need more specific guidance to those providing care in LTC, including around masking. I'm not sure we're going to be able to get to that at today's call, but I heard that, and maybe I'll flag it for you, David and Sasha, that LTC healthcare workers need some very clear guidance. So PHUs are going to be responsible for high-risk contacts in cases high-risk setting. What is a high-risk setting? The high-risk settings are these congregate settings, hospital, and some other healthcare settings like complex continuing care. We in primary care offices are not considered a high-risk setting. One really important point is that household members of cases will be asked to self-isolate regardless of vaccine status. And it is important to have your household members vaccinated with their third dose if they're eligible. And I think Alan Grill mentioned that some hospitals are allowing family members of staff of healthcare workers to book. So check out your local resources. I know that there are also now a number of other questions. I'm going to just end slides and I'm going to go to a few of the specific questions that have come up. And there's a number of questions about vaccinations. So I'm going to ask Allison for you to speak to one of the most common questions that people are getting and that we seem to be getting, which is that for kids age 5 to 11, NACI recommends an 8-week dosing interval. Should we be shortening that interval given what's going on with Omicron?
So I can tell you, we just need to wait for a minute. That is under active discussion in a whole variety of places. The trade-off is that we know that when you leave a longer interval, you get better antibody levels and better protection. And we're still waiting for more definitive data about whether there is an excess risk of myocarditis in this age group. And we have evidence now that extended intervals reduce the risk of myocarditis in populations in which it exists. So it's really, and of course, we don't have any data yet to tell us what the protection against from one dose or 2 doses is against Omicron in 5 to 11-year-olds. So this is a really uncertain setting in which people are thinking hard about trying to make the best recommendation for our 5 to 11-year-old children. I think there's probably going to be some recommendations coming out either from NACI or from the Ontario Immunization Committee. I'm hoping next week. So the answer at the moment is stay tuned. People obviously really want to do the right thing for 5 to 11-year-olds, and it's a complicated and difficult question.
Thank you, Allison. So just a reminder that as of Monday, anyone 18 over is eligible for the third dose, and the interval has been shortened. Maybe you can go back one slide, Olivia, and I'm going to just turn it to Shane. And Shane, can you speak to how maybe you are working to advance third doses and vaccines and support your community?
Sure, thanks. Well, I think when I was initially invited, there was no such thing as Omicron, or it was just it was just the idea. It was an idea in our heads, and so this. My presentation today was really to speak to our experience in the community as family physicians and how we were able to leverage our relationships with our community partners to be able to get vaccines into arms and to provide access for testing and for assessment, which was definitely lacking in earlier stages of the pandemic. With respect to what's happening now, is that we are expanding. We have the benefit of having an associated family health team that we have involved early on and have allowed, have not so much allowed, but have created a system where they can support vaccination while we have been supporting the recovery aspect of our response to COVID. So what we are doing now is physicians are getting more involved in vaccination themselves. We're opening up more time within our office, and we are also partnering with our public health partners to open up additional space in our assessment center for vaccination. So that's what's happening locally in our region. I can try to speak to, if anybody has any questions about what we've done, I can try to answer them. But effectively, what's happened in our group is our relationships that we've had over a long period of time with our region and our partners, specifically public health, the hospital, and Peel region, were able to utilize unused spaces for vaccination, initially assessment and testing, and we continue to do all three in those areas. But I understand the challenge in smaller doctors' offices to be able to do this not on scale is really a challenge, and we face that as we try to do it in our office specifically.
Thank you so much, Shane, for talking a little bit about what you do. Maybe we'll just end slides for a moment there, Olivia, and I'll go to some more kind of questions. I think that there were some questions just really about the practicalities of how we might use rapid antigen tests in our offices to keep ourselves and staff safe. I don't know, Peter, if that's something that you could speak to. How would we go about using rapid antigen tests? And I think there was a related question around, when we might actually see them get positive with Omicron in sort of an asymptomatic versus symptomatic kind of how quickly does that viral load increase?
So we have, of course, still very limited data about, the viral load dynamics in people. Perhaps, Allison, you've seen something I haven't seen yet, and you need to correct me. But it's highly likely, based on everything we know, that viral loads are even higher than before, and they come very early. Meaning rapid tests should be put into a position to actually perform even better than for Delta. And for Delta, it was already quite good. But the problem now is we will see explosive growth and we will have very high case numbers, meaning if you do that just once a week, the rapid testing for asymptomatic screen testing, you won't do anything. So you don't even have to start anymore if you do it once a week, okay? So it's really about doing it probably at least 3 times a week just for your entire staff. But it's basically one of the really big dangers here is okay, we do it and then everything is hunky-dory. We've been vaccinated 3 times and whatever. This is nonsense, okay? So it's just an additional layer, including a well-fitted good mask. Whatever the mask is, be pragmatic. The better fitted and the more filtration, the better. But that's okay. So you have the masks, you have the really great ventilation. Open the darn windows again and again, of course, and never, ever, ever, ever have lunch with your colleagues in the lunchroom anymore. Go outside, freeze, and have a sandwich. And for all of that, the additional thing is just a rapid test. It just gives an additional protection. That's all. And this means you basically just modify your risk that you just, when you do the test, infectious relatively strongly by 10, 15-fold probably. But the challenge is, since this is so dynamic, this doesn't tell you anything about the next morning. No, it could be completely different the next morning already. So you just need to be aware of that. Do it 3 times a week if you have tests, but all the other measures need to stay, and never trust anybody in terms of, as you said, it was beautiful what you said, Allison, an equal opportunity virus. Never trust anybody, not even Alison McGeer, if it comes to not transmitting the virus. That's the point, You look at people and you ask yourself, would they have unprotected sex with them? If the answer is no, you wear a mask and they wear a mask. It's as simple as that.
Thanks, Peter. I think another really common question we're getting, Allison, is, and others who want to jump in, is how about boosters for those 12 to 17-year-olds? So it's 18 plus now, and the 12 to 17-year-old, it's been more than 6 months for many of them. Why are we not recommending boosters for that age group?
So the 12 to 17-year-olds are an age group where, because they have a higher risk of myocarditis and because they have a lower risk of severe disease, you want to be really careful about balancing risks and benefits. And we just don't have data at the moment on Omicron to know whether they need additional protection. And we don't have data that tells us if they need additional protection, what are their potential risks of myocarditis. So, and then when you add to that, we're going to be working really hard over the next, 2 months probably, to get third dose vaccine to everybody. And very clearly, the priorities for third dose vaccine are to people who are going to get serious complications. So remember always that risk in COVID is primarily age-based. It's not like other diseases. It's not so much what your underlying illnesses might be. It's all about how old you are. Sad, but true for those of us who are older, I have to say. I think we're still 29. It's not true. So we really want to be getting it to older adults. And we want to be getting it to those adults that cause the most transmission. And again, COVID is not like other viruses. It's not young children and teenagers that are responsible for most of the transmission. It's the 18 to 40-year-olds, okay? Same people as are getting Omicron now. So I think not offering boosters to 12 to 17-year-olds is both about uncertainties about the risks and benefits to that age group and whether they really need it. It's also about trying to focus our vaccination program on vaccinating the people who need to be protected as individuals and for whom vaccine will reduce the risk of transmission going forward. But again, it's one of those evolving things. People will be watching it very carefully. If things change, you can expect us to change recommendations in probably 2 or 3 days, right? At the rate things are going.
Yeah. So lots of great comments in the chat. I think people are also talking about, I think people are just reminding ourselves that this has been a terrific session, but also maybe overwhelming, and this is going to be a stressful time. So we need to be there for each other, and remember to be deliberate about our acts of kindness, and also that many of us may need support. And so I've just reposted here a link to the physician wellness resources that the OCFP team and us have put together a long while ago. And so please do access those if you do need. I'm going to switch now. So I think there's one more question on rapid tests that I want to get to, and one around boosters as well. So one, Allison, around boosters is a fourth dose needed for people who are immunocompromised?
Yeah, so fourth doses, remember that for the list of immunocompromised people in Ontario, the way we're defining things at the moment, the primary series is 3 doses. And a booster dose after that 3-dose primary series is recommended on the same schedule as other people. So that would be 3 months now for the booster dose for immunocompromised. So yes, immunocompromised people, as soon as they hit 3 months after their 3rd dose, are eligible for a 4th dose.
Thank you for clarifying that. Peter, there's a lot of people just asking about, now rapid tests are available for the public. And I wonder if you have any advice for us on how to counsel patients on using those tests.
Yes.
I think many are like, oh, I can use that and then go to a holiday party as an example.
Yeah.
Is that recommended?
So there is even some audio out there now. I have had a rodent, how do you call that, horse and pony show yesterday on CBC through Canada, talking about rapid tests. You might probably find something there. I went through, how they actually do it, but also what the caveats are. So the first thing is, as I already implied before, this is not a magic bullet, for heaven's sake. So, you need to tell them, don't fall into the trap and say, okay, we all rapid test and then we meet 50 people and everything is hunky-dory. It's not. It basically, and we have good evidence on that already from Norway, other places, it's just simply not that easy. You reduce the risk, but you don't, just just reduce it to 0, it can still be quite considerable. So if you want to use them, it's for small intimate settings, 6, 7, 8 people who are meeting. You want to have an additional layer of protection. You do everything else still as good as it gets. And it depends on how close you are, of course, in your family setting, whether you will wear the mask or not. But then the point is you do the test immediately before that, because you want to have the situation reflected that you're in right now. Mind, if your meeting is 7 hours, 7 hours later, you could already have a viral load that is infectious. Nobody knows. So the point is 1 hour before, do it well. You will find probably some instructions there. It's really just basically be a little lab specialist and do the same that you would do with a pregnancy test, only that you need to prepare, of course, the liquid first. You can't just, do the same as with a pregnancy test. And then just an hour before, if you go to a next, and you shouldn't, of course, because you should reduce your contacts. If you go to a next party next morning, you'd need to repeat the test next morning because things could have evolved. And you would just really make sure that you don't use the rapid test as an excuse not to have as optimal protection as you would think about. And then the rest is then, of course, all the counseling regarding the meetings, as many people as possible should have 3 doses already, etc. And the point then is, if people, the thing with 2 doses versus no dose, the argument for no dose, that this is not a good idea if you meet with them, is you don't want to endanger those people without the dose. It's not anymore as before. 2 doses, hooray, risk is reduced and it's not a problem. We need to counsel people. 2 doses doesn't mean anything if it comes to infection, only against severe disease. So if you have really vulnerable people now, I just had the radio yesterday, somebody saying, the oldest is 93. The question really is, in this situation, do you want to meet with this 93-year-old woman, even if she has had the 3rd dose 2 months ago? Probably this 93-year-old woman should stay home anyway, etc. So you get the message right now. We have an issue with vulnerable people, and vulnerable people are now also all the unvaccinated, and everybody needs to get rapid tested. It's reflecting right now what you're seeing right now in the moment. Don't trust the rapid test for tomorrow morning.
Thanks. I also want to just deal with a practical thing just before we close. And that's, I think as family doctors, we have to continue to remind people that even if you have mild symptoms, you need to self-isolate, and that people who are doubly vaccinated, and I think we're seeing this more and more in our offices, people who are doubly vaccinated sometimes do have mild symptoms, but have Omicron and can be spreading it. And so we need to remind people to self-isolate. And the guidance is to have them do a PCR test. I think that is in some regions now becoming difficult because it is hard for some people to get access to the test quickly. So I'm just I don't know if anybody on the panel wants to talk about that, but I think we're going to need to think a little bit further ahead now too. So as testing becomes more difficult to access, so of course we can support that as family doctors, but perhaps we also need to think about, taking a rapid test at face value. If it's positive, it's positive. The rate of false negatives is extremely low. And
absolutely,
Peter,
especially with this pretest probability that we will soon have, we very, very soon will approach a post-test, a positive predictive value of 80% very soon. So, we need to be pragmatic. It's then even the same to say in the household, and, it will not just be very little symptoms. There will be loads of people out there with no symptoms, probably. I don't know. We will find out. Fully vaxxed, 2 doses, no symptoms, 3 doses, no symptoms, but still infectious. All of that will happen. We need to become very pragmatic. So yeah, 1 positive rapid test in the family, no rapid tests anymore. Don't worry, you just isolate the entire family and you don't do anything more. Things will change very rapidly because we will run out of testing capacity as well. Yeah.
I think the other thing that's really important here is not just doubly vaccinated people. Triply vaccinated people can get Omicron.
Absolutely.
And they can have mild disease. And so if you have symptoms, it does not matter what your vaccination status is. You need to be tested.
Thank you. You need to be tested. And if you can't get a test, then isolate.
If you can't get a test, you need to stay home. Yeah.
Yeah.
Exactly. And rapid tests work for everybody, irrespective of the vaccination status. And you can safely assume that the viral load, it sucks, but it's the same for 1, 2, 3, or 0 doses at the beginning.
And how long would you need to isolate for? This is maybe putting you guys on the spot, but I know that that's a question that's come up a few times. And as you're thinking about that, Olivia, I'll get you to bring up our last 2 slides.
So individuals, right, 10 days post onset of symptoms, and in the tiniest sample size ever, I have data on 3 Omicron cases in the community, all of whom who were still positive had cycle thresholds above 30 on day 7 or day 8, and so although Israel, you may notice, has changed their isolation period from 10 to 14 days with Omicron, I think we probably don't need to do that. More data coming, right? Wait till next week. Something might happen. But I think we're probably talking 10 days after symptom onset per case as you go through the household.
And you see, there's the problem. We need to be aware of that. We then still need enough bus drivers and cashiers in the supermarkets and everyone else. So we need to be pragmatic there too with the length. I completely agree with the 10 days. And again, what you can do in the end of the quarantine period, do a rapid test. If it's negative, you've been through 10 days and the rapid test is negative, that's a good sign.
Thank you, Peter. I think we're going to have to stay nimble and pragmatic as we move through this next phase. I think you've articulated, all of you, clearly for us why we need to reduce contacts immediately to stop our health system from being overwhelmed, and also to give people a chance to get a 3rd dose, because that 3rd dose is needed to protect ourselves against Omicron. And as family doctors, we have an important role to play to continue to provide essential care. We need to take care of ourselves to do that, and make sure that we are prepared, and then make sure that we can support our patients and support the COVID response regionally. And thank you to Sasha and David for providing us with some practical kind of insight into how we can access some of the resources that will allow us to do our work. Thank you to Allison for helping answer all of the really tricky IPAC and vaccine questions. Thank you to Peter for all of that you're doing for our province, and the advocacy that you're doing, and the public relations education that you're doing. Thank you to Shane for demonstrating how we can, as family doctors, make a difference in our community. Thanks to my co-host Liz, who helps always keep me grounded and focused in these sessions, and is of course supporting all of us through her work. And thank you to our back team who makes these sessions possible. It says here our next community of practice is Friday, January 14th. That's actually not true. I should have said that we are going to probably do another one earlier than that, but we just haven't figured out what date it is. A reminder that our session recording will be available on the website by the end of the day today. Please do share it with others, because as you know, I think there was a lot of valuable information. We will be posting a Q&A, but that will take us a little bit longer because we want to make sure that we're providing you with the most accurate, up-to-date information. So thank you all for tuning in, and thank you for all of the incredible work that you are continuing to do. Be kind to each other and stay well.